He's one of the course directors, of course. He will talk about an issue that is completely forgotten on the other side of the Atlantic, which is a terrible mistake of our American colleagues. But in the rest of the world, we still know how to do parallel wire.
Basically, it is a simply forgotten, simple method, but we can do a lot of things with parallel wire. A CTO PCI, you have a single wire technique or a parallel wire technique in antegrade approach and retrograde. I'm not going to the details, I'm just going to the parallel wire technique. When a wire crossed, but not in the right track, you have only 4 techniques to come out of that. You can redirect the wire, you can have a parallel wire technique, you can have a dual lumen catheter, or you can have an IVUS guided technique. So this is actually a case number 1. A CTO circumflex, the Gaia first is actually tried, the wire is not crossed. I tried with a Gaia second wire. Wire is going somewhere. Wire is actually taken. You can see the wire is out of the track. Once the Gaia second wire is out of the track, there are 2 ways to come out of this. One, you can actually have a parallel wire technique, or you can redirect the wire, or you can go a parallel wire technique. I decided to do a rewiring of the technique because then I can save 1 wire and I can just finish with single wire. So I redirected the wire with a dissection in the proximal part and cross the seat lesion. This is a simple way of doing. Go to the next case. This is a CT of LED, lesion not crossed with filled FC, and Gaia second again tried. You can see the wire is totally out of the track. Once the wire is totally out of the track, it's a real complex situation in this slide changing, so you should give me some time. Basic concept, the original guide wire will prevent the entry of an additional guide wire into the subintimal space. So you keep the wire in the subintimal space so that you can have next wire can go into the true intimal space. What is actually the parallel wire technique? 2 main purposes. Redirect a wire inside the body of the CTO and puncture the distal CTO fibrous cap. These are the 2 principles of that. The prerequisites, a distal true lumen should be visualized via the collaterals in angiogram. Then only you can redirect it. The contralateral injection often needed, or if you have a homolateral injection and can see the distal vessel, it is okay. And a high operator skill is not required. Not required, you can have a moderate operator skill also okay. Wire enters the subintimal space. Second guide wire is advanced next to the original guide wire. You can have a seesaw technique with 2 microcatheters and 2 wires. You can have 1 guide wire and 1 guide wire with a microcatheter, which is called parallel wire technique. Or you can use a dual lumen catheter and finish the case. So the parallel wire technique is the guide wire is in the subintimal space. It's a microcatheter used. The initial guide wire left in the space. Then you take the second microcatheter with a wire which can be crossed into the true lumen. That is a successful entry of the second guide wire into the true lumen. That is called parallel wire. In the seesaw technique, both the guide wires are in the microcatheter, you redirect. Almost only the technique is actually called seesaw and the other one. So the proximal cap is crossed, then the distal wire. Distal cap is not crossed, again you can use a parallel wire and can enter into the true lumen. So the wires used actually, a stiff polymer jacketed guide wire can like Pilot 200 you can use, or a stiff and a highly torqueable wires. You can use the most preferred wire as a Gaia series of wires, but you can use a Congress Pro 12 or a Miracle 6, Miracle 12. You should always use the second wire should be stiffer than the first wire and should have a superior torqueability is the better one. Congress Pro 12 and Miracle 12 does not have a superior torqueability, but Gaia series has a torqueability. So in the present case, what actually I kept my wire in the totally subintimal track. I've taken its third wire, that's actually Gaia third wire. Gaia third actually, you can see the distal wire actually, now the wire is redirected into the true lumen. So I'm actually just rotating and going down. Checking whether I'm in the true lumen or not, because one wire is already in the subintimal track, the wire is in the true lumen. Just rotate and go down. So this is actually a parallel wire example showing. So the wire is actually reached the distal wire, and this is actually the final result. We have put a stent and finished. So advantage is actually intra-occlusion tortuosity. When your first wire stretches the vessel and favorably modifies the curve, this makes the tracking with the second wire easier. So the increased success rate after failed attempt with the conventional antigrade wire technique is also there. For example, in a RCSCTO, this parallel wire technique, you have a wire and you have second, the wire will make the stretch the vessel into a, stretch the vessel and make it less tortuous, then your second wire will be having an advantage. That is actually another advantage, especially when you have an RCSCTO where you have a tortuous anatomy, you can have a second wire can be taken and make it parallel. You have another technique called dual lumen catheters like twin pass or twin pass dark, Crusade, Fine Duo, and Sasuke. A lot of wires are available, which is a lot of catheters available, which makes actually the second wire enter into the true lumen or the side branch. Here I am telling that this can be used in the parallel wire technique. The first one is a parallel wire. The first wire is actually in the subintimal tract, and the second wire can enter into that. This is actually a dual lumen catheter like Crusade or Sasuke can be used. Use of a dual lumen catheter for achieving a distal true lumen entry during antegrade crossing attempts once first guide wire enters a subintimal tract. Here is actually the wire enters into the septal artery. I tried with a second wire. Actually, this is actually a Crusade sitting there. Through the Crusade, I'm taking a second wire. The wire enters, and this is actually another use of a Crusade catheter, which is actually taken a second wire. Case 4, basically when you have sometimes you have a lesion which is actually distal to that. You have a wire, a lesion, after that 2 branches coming up. You have a diagonal as well as an LED coming up. We have taken a wire. The wire actually crossing into the diagonal. Real problem with audiovisual. I kept the wire, even microcatheter is there. You can have it is not crossed into the LED. I just dilated into the track. Then this is actually the second wire coming up. With the first wire into the diagonal, we could cross it. A wire goes into multiple places, but the second wire helps in taking the wire down. Small injection showing the LED, then I could cross the lesion down. Crossed already with the technology. So the problems with the parallel wire, prolonged parallel wire attempts can cause enlargement of the subintimal space and hinder a re-entry attempt. That is a major problem. You may try multiple times and you can create the subintimal space to go bigger and bigger, and then will be a problem. A second guide wire may follow the path of the first guide wire. That is another problem. And the third is actually difficult to visualize or adequately visualize both guide wires. And excess rotations can wrap around the wire and create a lot of problems, and both the wires can wrap around by the excess rotation. Remember, switch to a parallel wire technique before you create a very, very large subintimal space. That's a take-home message of the parallel wire technique. Thank you for the kind attention.
Thank you very much, Dr. Kumar. You mentioned it needs high skill level.
I told actually,
that-
it was written in the slide, I told high skill level is written,
But-
but moderate skill level is also sufficient, sir.
I
Even
think
actually low skill level, I cannot tell, moderate or high skill level. I made the change during my talk.
the argument is always that parallel wire is only for the highly skilled. And that is what I think is wrong.
Sir,
It's
actually-
more important, more difficult to place the first wire than the second wire, isn't it?
Right, sir. Actually, I made the change during my talk. I told highly skilled, you should forget about it, moderate or high skill, not low skill level. That's all only point.
Any questions?
Dr. Werner is trying to be very generous by calling all those people who are using parallel wire technique as those who are not very skilled. But I think the first thing is to start CTOs. And if you fail with one wire, then start a second wire. So you need at least moderate degree of skill.
Thank you.
Okay, thank you very much.